um, in very dangerous, condition. But remember, we see a kid, we see a little child, we see a newborn, we see like an infant, a school age kid or an adolescent. So they a lot of time they cannot tell us how they feel. They cannot tell us how they the symptom. They cannot describe the symptom to us. So let's say a lot of time I say that we have the indirect history and indirect examination. So they cannot tell us. So we're gonna have to try to get information from the parents, or from the patient indirectly. So, and then every group, every age group, they have different, diseases like anatomical, physiology, developmental characteristics different. So they have very different, condition that, like in different ways how they present it. So, abdominal pain is a very challenged, topic, in pediatric, even for an experienced doctor like me. So, so that's why I bring it up with Dr. Min. So what we want to discuss about this. So for you guys good with us? Is it too fast?
Good.
Okay, so the first thing, to you remember that the child going to see us, they're really scared. When they see the doctor, they're scared. For them, the white coat, syndrome, the white coat symptom is very prominent. A lot of time I see the kid when their blood pressure is shooting up and for no reason because they just, they see the doctor, they're scared. So and when they're scared, they cry. And when they cry, you cannot do anything with the abdomen. So they're very important that when you see the child, the first thing to do is to build a good patient-doctor rapport. The rapport means the relationship. So we have to make friends with them before we come in. Don't just jump in and say, okay, what you have. You have a fever, you have abdominal pain, let's lay down and check your belly. It's not going to work that way. So a lot of times you're going to have to, just like with the little kids, like a 2-year-old kid. You go and you see them, you're going to have to kind of make friends with them first. Make friends with the parent, make friends with the kids. So a lot of time I go to the room, I watch the patient, I go and say, hey, what's your name? Like, oh, you have the stuffed animal? What is his name? So is it your friend? Is it a boy or girl? You kind of play with them to kind of build a relationship before you're gonna touch them. So it's better. So the very important when you see a kid, you build a patient-doctor rapport first. So have to make sure that they're not scared of you, or they friendly, they feel comfortable, talking to you, or let you touch them. So that so for the rapport. So remember, we see the challenge in a pediatric. You see the patient from newborn to 18 years old, meaning that you see it's all the different ages and developmental, stages of a person. You can see newborn, they don't know anything, they just poop and, like eat and sleep, that's all they do. Or you can see the almost like an adult one, like 18, 17-year-old. So to establish the rapport with them, so you gonna have to, try to create a friendly, a comfortable environment for the child to make friends with you, but depends on what their age. You have different ways to do that. So you have to use different language. You have to use different, approach for different age. Let's say you see the 2 months old, a baby, you don't have to do much. You have to make report with the mom because the baby is just 2 months old. There's nothing to communicate much with the baby. But when you see the 2 or 3 years old, you're gonna have to go there, and then they're really scared, so you're gonna have to make friends with them. A lot of time I go there and say, hey, how are you? Like, well, how are you doing today? So can I see your, your toys and what toy you have? Or like I would say, oh, I like your outfit, I mean the clothes and the shoes and stuff like that. Or if they come for Halloween dressing up, oh, what are you today? Who are you today? Thing like that. For the preschool, the preschooler, it's actually it's a little challenging because of preschool means 3 to 5 years old. For preschool, they are know a little bit, but they're not very, very comfortable with you yet. So they kind of in the middle. They're not a baby anymore. They know a little bit. They still scared. So a lot of time they come and they're very anxious. When they answer, we have to make sure you you make friends with them, because the first thing with the pediatric, if you make them feel comfortable with you the first time, and then the next thing, the examination will be much easier. And when the examination was easier, the whole thing will be easy. And then the next visit will be easy too. So if they comfortable, but they like you, and then they let you do whatever you want, but they don't like you, they cry, it's very hard to do whatever next thing to do. So for school age children, they know they 6 to 12 years old, so they know they're not usually don't cry much, but they still not mature enough to tell you what they feel, how they feel. A lot of times you ask a kid like 10 years old, how do you feel your belly? I don't know. It's just a little pain, and the way the pain they just point everywhere. Like a lot of times they cannot tell you exactly where it is. Adolescent, they most likely adult, so it's easier to communicate with them. And then, a lot of times you can, build a trust with them, and we'll have a very good, conversation with them before, and then you can get a good history from them. So a lot of time I go to the room and see a adolescent. I usually talk to them more than talk to the parent, because they can tell you how they feel, what they feel, and then you can do examination much easier on that. So, for example, so to establish in the report, so yet you have different way to talk to the patient. Let's say for the infant, which is less than 2 years old, you can say, "Today I'm here to help you feel better. We take good care of you. Let's play a little games when you examine your tummy, and you show me where it hurts." Remember, when you talk to the kids, try not to use so many medical terms. Say something, more like slang, daily spoken language. Let's say instead of say defecation, bowel movement, and you can say pooping. Number two means go poop, and number one like peeing. Instead of say defecation or bowel movement, they're not going to understand that. Instead of say abdomen, you say tummy, you say belly. Now the umbilicus, you say belly button, and stuff like that. So for the preschool age, like 3 to 5 years old, they know a little bit to play, and a lot of time they love to play. So a lot of time you go and then, okay, see, I have a special stethoscope and listen to your heartbeat, which you would like to hear too. A lot of time actually I put the stethoscope into the patient ears and have them listen to their own heartbeat. So then they love it. When they love it, they think you're friend, and they think easier. So like sometimes your tummy can feel like a crumbly monster. We try to find out what's causing it. So, and then for the school age, it's easy to talk to them. You can say something like, "I'll be asking some question about your tummy. Your answer will help me understand how to help you feel better. I'm going to use a tool called thermometer to check your temperature. It's just like a quick peep on your forehead." All the lesson easier. You can talk, with like adult with them most of the time. So let's say it's important for me to hear about your symptom in your own words. Like you can be honest with me. We figured out the best plan together. I explain the tests we might need to do and what they involve. If you have any question or concern, feel free to ask. A lot of time, the adolescent would love to hear the plan of the treatment, to hear what they have, and they will discuss with you how they feel about their condition and what their concern is. So don't only to talk to the parent, have to talk to the patient too for adolescents. So any question for this part? Like establishing the rapport, meaning like make friends with your patients before you go even see them, especially for the little one. Like I would say less than 5 years old, try to make friends with them first. So we good? Any question? I'm too fast?
Seems like we good. I think you can keep moving on.
Okay, let's go. So of course, for any encounter, after you make friends with them, you're gonna have to try to make a good gathering a good, thorough medical history, which is very challenging for pediatric. And a lot of time, because a lot of time they're not able to tell you what's going on. They're not able to tell you how they feel, what they feel, or so a lot of time you get the indirect history through mother, and mother just like us, mother just observe the kid and tell you what they see, what they guess, but they not the patient telling them. So a lot of time, the patient coming with one complaint, would come to another condition. Let's say a child can come with the abdominal pain and the chronic intermittent diarrhea, but then the diagnosis final going to be constipation with the same thing, like they may come with the chronic intermittent diarrhea, and then they can maybe like a irritable bowel syndrome, so different stuff. Or sometimes, kid, come in, like let's say a 1-year-old kid come in with abdominal pain from intussusception. They're not gonna tell you how they feel. So a lot of times you have to ask a parent, like, do they have? What are you gonna ask them? You ask them, oh, do they have intermittent abdominal pain? The mom doesn't really know it. The kid's not gonna tell you. So you're gonna have to ask them, like, does the kid sometimes like suddenly crying loudly, like somebody pinched them, like like Vietnamese say "nhéo," like somebody pinch them, and then suddenly they're quiet, they cry so loud, and then like really something really painful suddenly. So, and that's why it's very, very, very important for you to learn how to get the medical history, from the mom or from the patient that's not able to tell you everything. So, and then when you do that, try to do more with the open-ended question to allow to the child to tell you what they see, what they feel, like especially for adolescent or for school-age kids. So to do open-ended question, let's say, oh, how do you feel? How do you feel like your belly? Like how does it feel like? Instead of you say yes or no only, it will help them to participate with you, and then you're gonna get more information from them. So like a lot of times you go and you see the kid and say, where's the pain, and then where your belly hurt, and then they will like point somewhere and say, oh, can you tell me with one finger to where it's hurt the most, and they will tell you. But I try to communicate with them more to get better information from them. So let me go to the next one. So remember, the question should be more thorough and systematic. So we always talking about the old card question, like it stands for onset, location, duration, characteristics, alleviating or aggravating factors, radiation, times, and severity. So make sure you go through with that. And a lot of time with the little kid, you're gonna have to ask it from the mom. So, and then you have to ask in different way, depends on different age and different, group of patient. So from the baby, the infant, a lot of times most of the time you have to ask the mom. So you're gonna, instead of, have the mom, so instead of like, you're gonna have the mom like have the baby been crying more than usual, acting uncomfortable. So that's saying that the baby may have in pain. Have you noticed any changes in your baby appetite or how they feed? And is your baby having more difficulty sleeping or settling down? So things like that will tell you the baby in pain. This is a lot of time the baby not gonna tell the mom they hurt it. The mom gonna is describing to you something like the baby in pain right now. And then the baby older, you're gonna ask them directly, can you show me where your tummy hurts? Is it here, somewhere else? Can you show me with one finger where it hurt the most? Or when the pain comes and go, or is it there all the time? And then have you noticed, any changes in your bathroom habits, like going to go to the toilet more and less often? Most of the time I use like, okay, have you pooping more, or then when was the last time you poop? Or when was the last time you pee? Or when you have diarrhea, things like that. I usually don't use much with the bathroom habit or bowel movement because for the kid, lot of time they don't understand. So, and then for the school age kids, which is 6 to 12 years old, you can say something like, when did the tummy pain stop? Was it today, yesterday, sometime before that? Can you describe the pain to me? Is sharp, dull, crampy, or something else? Or you can say, do something make the pain better or worse, like eating, moving, or resting. Other lesson, you can ask even more. You can tell me the onset of the pain. It did start suddenly or gradually. So on a scale of 1 to 10, with 10 being the worst pain you can imagine, how would you rate your intensity? So have you noticed any other symptom along with the pain, say that nausea, vomiting, fever, or changes in bowel movement? Like try to get more information, either way, directly or indirectly, the best you can. So it help us to make a good, encounter. So through the medical history, not only with the pain, we asked about the pain already, the abdominal pain, we really have to ask the symptom going with it, like combined with it. So let's say most of the things you're gonna ask about nausea, vomiting, change in bowel movement or appetite, such a thing like you ask like sick contact, like have there been anybody around with same symptom, anybody at home, at school, or daycare, have like same thing, abdominal pain, vomiting, diarrhea as well. And then if the kid have vomiting, gonna ask like how often is your child have been vomiting, or any blood in there? What did they vomit up? Any blood or bowel like liquid, or like green liquid when they vomit. And if they have diarrhea, gonna have like how many times they have diarrhea, like yesterday or today, and then any blood or mucus in the stool, and like, and then like you asked about like, is it related to the food? Is it associated with eating a certain food, or after eating they hurt, or before eating they hurt? Those things we have to come into the question. So let me see, and then more thing to ask. Usually you have to ask about dietary changes, travel history, or relevant medical condition or medication. So for example, you can ask, have you noticed any changes in your child diet, activity, routine around the time the symptom begin? When they're having pain? Usually I ask, like, when they're having pain, are they still able to eat or play, or they just lay down, or they cry until you can see, is it the pain interrupting with their daily activity or not? And then like, you have anybody around with the same symptom? And then are they taking a medication or any chronic medical condition that we should know or we should be aware of? And then, of course, when the kids have fever, abdominal pain, diarrhea, you're gonna have to ask them, have they traveled anywhere lately for the last few weeks? Those things have to come to ask for history. So So any question for medical history? So remember, when you ask about medical history, you have to different way to ask. It depends on different age, infant, preschool, school age, and adolescent. It's a different way to ask. You can ask directly, you can ask from the mom, and try to get the best medical history that you can. So, and the next step will be a physical examination. Of course, try to do, the very comprehensive physical examination. For pediatric, remember we examine the baby, and then sometimes the teenager, like adolescent. So first thing you need to do is ask for permission to do physical exam. You ask the patient or you ask the mom. And especially when you're gonna check the genital, you check let the patient have abdominal pain. You may have to check the testicle, the genital, to make sure they don't have any hernia down there, or sometimes the abdominal pain can be testicular torsion. So you're gonna check down there. So first thing, you're gonna ask the parent to do that, or the patient. A lot of time I have to, we're gonna do examination. Can I check you that? Check you that? Or ask the parent, ask the patient as well. And then usually try, so we work with the kids. So try to talk with them when you do examination. So a lot of time I tell always tell the patient, oh, I'm gonna check your heart. Okay, your heart beating well. I'm gonna check your lung. Okay, and we're gonna go see your ear to try to see the bunny in there. Oh, check your mouth. Can you open your mouth? And then, for the belly, you're gonna have to ask them to lay down, and I'm gonna check your belly now. So every time you communication with them, it will help them to cooperate with you better, so you can do a better exam. And then when they comfortable with you, the exam must be easier. Remember, we check the kids when they cry. The abdominal exam will be very limited. Like, it's hard to do that. So if they don't cry, they let you do it. It's much easier. So try to, to make it peacefully for themselves. And then a lot of time when you see the kids, especially when you examine the kids, especially the school age adolescent, you may have to try to talk to them. What are you doing right now? So you can look into the scenario, but a lot of time you're gonna say, "Oh, I'm gonna check your liver. I'm gonna try to touch your belly, palpate to see it pain anywhere, tell you where it's hurting." And then a lot of time the kid won't tell you, but you can see how they express. I trust the expression more than what they tell us, especially for us, like a 6 to 7-year-old. A lot of time you touch them, they hurt everywhere. You get, oh, hurt here, hurt here, hurt here, but they don't seem like they're hurting at all. So their expression, what they're showing is very important. So try to talk to them and then tell them, I'm going to check your liver, I'm going to palpate, I'm going to do the rebound tenderness, which is going to tell them, okay, I'm going to do the deep touch in your belly, and they're going to release fast. I'm going to tell you, you're going to please tell me, is it hurting more? So explain to them what you're doing, so they can help you. They can work with you on that. Sorry. Okay, so remember, different child, different age, they have different developmental stage. So the way they present the abdominal pain is different. The way they actually show the symptom to you different. So a lot of times you're gonna need, the help from the parents to tell you what they feel. So the mom might tell you something like this for a baby, like the baby is fussy and cry a lot, meaning the baby not happy, especially when they touch or grab their belly. They keep pulling their legs up and their tummy, and they seem uncomfortable during feeding, or they not eating. And then that for the baby. And then for the preschool age, they will tell you a little bit more, but not very in detail. They say, oh, my tummy hurts. it feel like there's a big ball inside. It hurt more when I eat, or I feel sick in my stomach. But a lot of times they cannot tell you, where exactly they're hurting, or like more information about it. And for school age, they tell you a little more. I have the sharp pain in my belly right here. Most of the time they can tell you. Sometimes it hurt more after you eat, being going to the bathroom a lot, or not at all. Other lesson they will describe to you more. I've been having this cramping pain in my lower abdomen. It comes and go. It works when I'm stressed or anxious. I'm also noticed some bloating and changes in my bowel movement. So different age have different way, different presentation. So we're gonna have to adapt. We have to try to get the best out of it, but we have to adapt it from case to case. So even like sometimes when you see the adolescent, but they are autistic, they have autism. When they have autism, they're not gonna tell you anything. So you're gonna have to work with adolescent the way you work with the infant, just like a baby. So that's very important for seeing a kid, with abdominal pain, or with any other, complaint. Like you have to see how old are they and how developmental state are they are right now. So with that, you're gonna have to, changing the way you communicate, and the way you asking them depends on their age. So it will help you to make a good, accurate assessment, and then build a trust and cooperation between you and the patient, or the mom or the parents. So and then from there, it helps you to make a good diagnosis, and of course the treatment plan later. So you're gonna see more, the way you can approach your different age, like infant, toddler, teenager, in the scenario you can practice later. So, okay, give me one moment. So abdominal pain in kids, most of the time you see a pre-benign one, which is something not serious. Can be most of the time you can see constipation, gastroenteritis, which is viral infection of the intestine, or like or just functional abdominal pain. Sometimes maybe something that not really relevant, but sometimes you may have serious cases, which is have to make sure that you catch those red flags. We mean that the side that can be a dangerous condition. So that's a very important, for that for to see a kid with abdominal pain. So a few red flags I'm gonna mention, not all of them. So, but first thing is severe pain, or the pain is getting worse. So a lot of time, you're going to ask a patient, how would you rate your intensity of the pain on a scale of 1 to 10, which is 10 is the worst pain you ever have? Or is it a pain get worse over time, like worse than 2 days ago? Or are there any specific like activity or movement that make the pain more intense? But tell you the truth that a lot of time, the little kid, the kid may not able to tell you how bad the pain is, but you're gonna have to observe them from the moment you get into the room. So a lot of times you go to the room, the patient says, "Oh, I haven't pain," but they sit and they play video game. Doesn't seem like a bad one, but the kid they're like acting like having a lot of pain, like with the face and the painful face, or they walking with a gait, or they like very irritable, like they look tired and look exhausted, and then that's more even more important than like how they rate the pain. So a lot of time you go there, you take a look at the patient, you see how they doing right now. So if they're so happy, playful, maybe not a bad deal. So, but if they look sick and they look very, like tired and then you maybe have to be careful. So, and then where they having pain, it will be, important too, because of a lot of time, the more localized they can, pinpoint the pains, it will be more, concerning. So let's say they have a pain, but they said, well, it's everywhere. They point everywhere, and that less concerning. But the pain, they point one spot, like the lower quadrant, the right lower quadrant, which is appendicitis, or somewhere else. That's really more, like concerning. Or they say the pain get worse with the deep breath. Whenever they take a deep breath or they do something, it gets worse. So, or the patient having pain with the distended, like abdomen, like distension. It can be, obstruction, can be a lot of things in there. So when you examine, of course, we talking about rebound tenderness. So when you release the pressure, after pressure on the abdomen, and then does the pain worsen? Actually, a lot of time I do with the patient, and then I will tell them what I'm doing. So I tell, okay, I'm gonna deep breath in here. Okay, does it hurt? And then I release it suddenly, and then I'll ask them, does it hurt more? And then the kid may tell you so. And then of course, so if you have the kids with, rigidity, like when it feels so rigid, like the belly is very firm, the abdomen very firm. So, but it's not actually it's very rare in the children to have these kind of thing, but we mentioned it here. And then if the kid vomiting, be careful, because vomiting can be, something, tricky with the abdominal pain. Abdominal pain with vomiting sometimes it can be, dangerous. So have to make sure that they don't have any blood or bowel in their vomit, and then make sure that any particular time of the day or specific trigger that seems to provoke the vomiting. And then when the child comes with abdominal pain and high fever, and be careful as well. It can be a bad thing. So it can be, like something like appendicitis or the bad infection, and sometimes they come in with the abdominal pain and high fever, sometimes vomiting. It can be a strep throat, like a strep pharyngitis. And then anything with blood will be concerning. So patient have diarrhea with blood, patient vomiting with blood, and then it will be alert, will be the alarm inside that you need to be careful. So you have to ask the blood mixed with the stool or the separate. Or like a lot of time the patient tell you after they do number 2, which is pooping, and then they have some, like dripping, like blood dripping, which is more compatible with like constipation. So we're going to ask about a constipation as well. And then anything change with the color, the consistency of your stool. So, those things you need to ask. So when a child comes in with abdominal pain and vomiting, diarrhea, then you're going to have to, ask about dehydration. So dehydration, of course, you're checking the skin, you're checking the different stuff, but you're going to have to, ask like how frequently are they urinating, or have you noticed any change in the amount? A lot of time the patient, the kid, I changed only 2 diapers today. So instead of like, usually we change 6 diapers, but only 2 diapers today. So a lot of times they tell you indirectly, not like urinating, because the baby cannot tell you how many times they urinate every day. So, and then you feel the mouth, the mouth has become dry or parched, or any dizziness, fatigue, or reduced energy level. And then, of course, any abnormal vital sign like blood pressure, like pulse, like tachycardia, and high fever, anything like that with the vital sign will be concerning as well. And then when the patient like present to you with the sudden severe atypical, abdominal pain will be concerning as well. So those things, keep in mind that, like when you see a child with abdominal pain, there's a lot of thing that you may have to consider, and then try to catch the bad cases, which is, try not to miss all the red flags. So to wrap it up, so usually when you see the children, the child with abdominal pain, several steps we need to try to to do it well, which is, first thing, remember to build a rapport between you and the patient. Don't just jump in and like check the patient, and then make sure make a good history taken, like taking good history through the mom or through the patient from different ages, and do a good examination. The examination can be very tricky with the little kid. They're not going to tell you where they're hurting or how they feel, and then that's why you have to put the developmental stages into consideration, and make sure that you don't forget the red flags, and then evaluate the red flags. And we treat the patient as a whole, not just the belly, so not just the abdomen. So even patient coming with abdominal pain, remember to check everything. Remember to consider every different possibility, because a lot of time the patient coming with abdominal pain will turn out to be something else. And that's why we check the holistic approach. And then try with this, I hope I can help you to get, to do a better, communication, and get a better, information from patient, and we do well with the abdominal pain on the pediatric population. So I think that's it for me to talk today. And then, you guys have any questions?
I think there's a lot to absorb, and then we're gonna practice later on. I think Dr. Hưng, Trương go over time a little bit, but I think because it's really important to make sure you have the good rapport with the patients, with the parents. So I suggest after today, go home, have your own set of questions that you think you may need to ask, and then practice on those set of questions. You don't have to ask different questions every single time, but find the question that you feel most comfortable. Make sure they understand you correctly. But one thing I think also very important is find the right level of the patients to talk to. If you use complicated words to the young kids, they may not understand you. But if you treat the teenagers like a school-age child, they may not like you either. So make sure you speak with the proper word to the proper group of patients. You have to feel for that to find the right way to do with experience.